Okay, let's dive in. You sent us a stack of sources covering everything from cannabis in cancer care to its effects on your brain and performance.
Yeah, it's a huge topic.
It is, and it feels like it's absolutely everywhere right now, but making sense of the actual research, that's the tricky part.
It really is. The body of research on cannabis is incredibly extensive and, frankly, quite messy at the moment, you know?
Exactly. And this deep dive is specifically for you, our listener. We're going to go through your material, randomized controlled trials, observational studies, literature reviews, even massive meta-analyses.
All kinds of stuff in there.
Right, and figure out what the most important takeaways are. Our mission, to cut through the noise, find the key insights from your sources, highlight where the science has found some ground and where it's still uncertain.
Yeah.
And help you understand what really matters in this fast-changing field.
We'll navigate this evidence base together, pulling out the threads that connect and also the points where things diverge.
Okay, let's unpack this pile of fascinating sources you sent us and see what they reveal about the current state of cannabis research, focusing on the potential benefits and, the effects on the mind and body. So, diving into your material, one of the first things that jumps out is the sheer challenge of even studying cannabis. Your sources, especially that first one, highlight how diverse this research landscape is, making it tough to get a clear picture. What makes it so complicated?
Well, that source nails it by calling the existing literature heterogeneous.
Right, heterogeneous.
And what that means is, well, think about it. Researchers are looking at wildly different things. Some studies focus on using cannabis for palliative care.
Yeah.
Managing symptoms like nausea or pain for patients undergoing chemotherapy.
Okay, symptom management.
Right. But then others are investigating whether cannabis compounds might have direct anti-cancer properties, trying to shrink tumors or slow progression.
So the goal or the question of the research varies wildly, very different aims.
Exactly. And the research methods vary, too. You've got randomized controlled trials, which are, the gold standard for testing if something actually works by comparing it to a placebo.
The best kind of evidence, usually.
Usually, yeah. But you also have observational studies, which just watch groups of people over time to see if there are associations. And then there are case reports, which just describe what happened with one or maybe a few patients.
So different levels of evidence, really.
Right. All valuable in different ways, but they don't produce the same kind of evidence. You can't always lump them together easily.
And that mix of goals and methods makes it hard to combine everything cleanly, to get one simple answer.
Precisely. This diversity, while it shows immense scientific interest, creates significant challenges for building a unified picture. That same source notes that this lack of a clear, consistent consensus across studies is a major obstacle to developing evidence-driven standards of care.
Evidence-driven standards, basically clear guidelines doctors and patients can rely on.
Exactly. Like, for this specific condition, use this specific cannabis product at this dose and expect this outcome. We're not really there yet across the board, based on the overall picture from these diverse sources.
It seems like it.
And there are other layers of complexity, too. Studies use different patient populations, different ages, different health conditions, different levels of prior cannabis exposure.
Okay.
And crucially, the cannabis itself varies hugely. Different strains have different levels of THC and CBD, different minor cannabinoids, different terpenes, you name it.
So many different plant chemicals.
Right. And the products come as oils, inhalables, edibles, tinctures. All these differences mean you're often not comparing apples to apples.
Which, logically, can lead to those divergent outcomes the source mentioned. Some studies find one thing, others find the opposite.
Exactly. It makes total sense why it's so hard to synthesize.
So how do you even begin to make sense of potentially thousands of studies with all these variations? Your first source mentions a pretty cool tool called sentiment analysis. That sounds like something out of Silicon Valley, not medical research.
It is fascinating how they applied it here, isn't it? Sentiment analysis, as described in that first source you sent, is basically a computational technique.
Okay.
It uses natural language processing algorithms read through text, in this case, massive amounts of scientific literature about medical cannabis.
Thousands of papers.
Right. Thousands. And they analyze the language to figure out the overall leaning or sentiment. Is the text generally reporting findings that support the use or efficacy of cannabis for a given topic, or findings that do not support it? Or are the findings just, unclear?
So instead of a human trying to read thousands of papers and keep track, which sounds impossible,
Yeah.
a computer's doing the heavy lifting.
Exactly. Its primary advantage is its ability to process and analyze massive data sets far beyond the capacity of manual review. Imagine trying to manually categorize the findings of, say, 8,000 research papers. It would be an immense task for a human team. Sentiment analysis lets researchers get that bird's eye view of trends across this huge body of work.
Okay, I get the power of scale, but like you said, medical texts aren't exactly full of emotional language. They're usually pretty dry. How do you apply sentiment to a factual scientific paper?
That's a really key challenge, and the source acknowledges it. Scientific writing is often factual and nuanced, not explicitly positive or negative like a movie review. A paper might report a finding without saying, "This is wonderful news," or "This is a disaster."
Yay.
And also, common phrases or banal terms appear frequently but don't really signal support or lack thereof. They could potentially muddy the waters, dilute the sentiment signal.
So how do they ensure the analysis is actually capturing meaningful trends and not just noise?
Well, they use rigorous validation methods. The source mentions cross-referencing the algorithmic findings with expert human evaluation.
Ah, so they check the computer's work.
Exactly. Having humans manually review a subset of the papers the algorithm analyzed to see if the computer's classification supported, not supported, unclear, actually matches what a human expert concludes. They also use hybrid models combining different computational approaches, rule-based, and machine learning.
Okay.
And transparency about the limitations is crucial. These findings need to be interpreted carefully alongside the broader context of all the research. It's not a magic bullet, but a powerful tool.
I noticed the source also talked about an alternative analytic lens or a separate methodological approach using keywords. What was that about?
Yeah, that was interesting. To get, as they put it, greater clarity and granularity, they used a different way to calculate the overall sentiment of each study. Instead of just looking at general language, they looked specifically at the preponderance, basically the dominance of certain sentiment-related keywords within each study.
Okay, specific keywords.
Right. And they assigned what they called a zero-sum sentiment dominance score to each study based on these keywords.
Zero-sum sentiment dominance. That sounds technical. What does that mean for me trying to understand this research?
Think of it this way. For each study, they counted how many specific keywords suggested support for cannabis use in that context, how many keywords suggested a lack of support, and how many were unclear. Under this dominant instance, or DI method, if a study had, say, more keywords pointing to supported findings than not supported or unclear keywords combined.
Then the whole study gets flagged as supported.
Exactly. The entire study was classified based on the overall leaning of its specific sentiment keywords. It's classifying the dominant message of the article, not just counting every single keyword occurrence scattered throughout.
Ah, got it. So one approach counts every relevant keyword instance they find. They call that keyword occurrence, or KO, right?
Right, KO.
And the other approach classifies the whole paper based on which type of keyword sentiment is most common within it. That's the dominant instance, or DI.
Exactly. KO counts the words, DI classifies the paper's main thrust based on those words. And comparing the results from the KO method to the DI method serves as a kind of sensitivity analysis.
A way to check if the results hold up.
Precisely. It's a way to check if the findings are consistent regardless of the slightly different way you're measuring sentiment across thousands and thousands of documents. If both methods largely agree, it increases your confidence in the overall trend they're identifying.
That's a really smart way to handle such a massive, messy data set. Okay, the big question. What did this sophisticated analysis actually find about the overall sentiment towards medical cannabis in this huge body of literature? What did the research studies tend to conclude overall?
The results are quite striking, actually. Looking at Table 5 in that first source he sent, the dominant instances, DI, classifying each article based on its main leaning.
Okay.
Out of over 7,900 studies classified this way, 71.4% were classified as supported.
Wow, over 70%.
Yeah, and 25.6% were classified as not supported, and just 3.0% is unclear.
Okay, so the clear majority of studies, when you looked at their overall leaning using that DI method, reported findings that supported medical cannabis in some way.
Yes, a clear majority. Now, looking at it the other way, the keyword occurrences, KO, just counting every instance of those sentiment-related keywords.
Right.
Out of nearly 40,000 keyword occurrences they tallied, 64.6% were supported keywords, 30.7% were not supported, and 4.8% were unclear.
The percentages are a bit different, but the trend is the same, a definite leaning toward supported findings in the literature overall. Still well over 60% supported.
Right. The DI method shows a slightly stronger supported leaning, maybe because it classifies the whole paper's intent, while KO, counting individual words, shows a bit more representation for not supported.
Makes sense.
What's also interesting is how few studies fell into the unclear category. It was the least frequent result in both methods. This aligns with the source's comment that thoroughly inconclusive or ambiguous results were relatively rare. Usually, studies tend to have a finding, whether it supports the hypothesis or not.
They tend to conclude something.
Right, and the source pointed out something interesting about the search terms they used too, didn't they?
Yeah, what was that?
Well, even though they tried to use a balanced set of search terms, roughly similar numbers of terms associated with supported versus not supported sentiment, the actual occurrence of supported keywords in the literature they analyzed was much higher.
So the pro-cannabis keywords just showed up more often.
Essentially, yes. This suggests, as the paper puts it, a tendency within the corpus to lean towards reporting supportive findings. Now, this doesn't automatically mean publication bias, but it's an observation about the aggregate direction of the research that's been published and analyzed.
Okay, that's a really important nuance. Here's where it gets really interesting for me. Connecting this big picture sentiment analysis to specific health areas, particularly oncology and inflammation, which were a focus in your sources. What did this vast analysis uncover about cannabis in cancer care, specifically?
Right, focusing on oncology, the meta-analysis confirmed that the literature covers both those areas we talked about. Palliative care for chemotherapy-induced side effects, and also investigating cannabis's potential as an anti-cancer agent.
Two very different goals. Again, palliative versus trying to treat the cancer itself.
Exactly. The analysis looks specifically at what they called cancer dynamics results.
Cancer dynamics.
Yeah, meaning studies reporting on effects like cancer progression, whether cannabis had anti-carcinogenic effects, effects on tumor growth, tumor size, and remission. These are the areas where researchers are trying to see if cannabis can directly impact the cancer itself, potentially as a, complementary treatment.
Okay, so did the sentiment analysis find strong support for cannabis as a direct anti-cancer agent in these dynamics?
Well, the source provides one specific correlation from its extensive analysis related to this: tumor growth. It showed a weak positive correlation with supported sentiment.
Wait, a positive correlation?
Yeah.
Between tumor growth and supported sentiment. That sounds backwards. Shouldn't it be negative if cannabis is helping?
It absolutely sounds counterintuitive, and this really highlights the complexity and, frankly, the limitation of just looking at a single correlation number without context. The key here is the strength of that correlation. The R value, the correlation coefficient, was 0.040946.
Okay, 0.04. How strong is that?
It's very weak. The researchers themselves set a threshold for significance at an absolute R value greater than 0.01, so 0.04 just barely crosses that threshold. It indicates an extremely subtle, almost negligible, positive association.
So technically, statistically significant, because the data set was huge, but the actual relationship is tiny.
Precisely. So what does this mean for you trying to understand this? It means that across this massive collection of studies, there's a very subtle tendency for studies discussing tumor growth to also contain language that the algorithm classified as supported sentiment towards medical cannabis use in oncology.
But why would that be?
Well, think about it. Many studies involving cancer patients focus on palliative care for people who have tumors. So the supported sentiment might actually be reflecting support for using cannabis to improve appetite, or reduce pain, or manage nausea in patients who have tumors, rather than reflecting a sentiment that cannabis has actually reduced the tumors themselves.
That makes a huge difference in interpretation. It's supporting cannabis for managing symptoms while someone has cancer, not necessarily supporting it as a way to get rid of the cancer.
Exactly. The source emphasizes that weak correlations like this require huge data sets just to be detectable, and you have to look at both the statistical significance, the p-value, and the strength of the correlation, the R value. Given how incredibly weak this positive correlation is for tumor growth, it certainly doesn't provide strong evidence from this specific analysis that the literature broadly supports cannabis reducing tumor growth.
Okay, that clarifies that finding significantly. What about the palliative side of cancer care? Managing those symptoms. Did the analysis show more clarity there? Was the sentiment stronger?
Yes, it did. The meta-analysis found much stronger evidence supporting cannabis as a palliative adjunct to cancer treatments.
An adjunct, so something used alongside standard treatment.
Right. While the full details aren't exhaustively listed in the excerpts you gave me, the source mentions examples of reported benefits summarized from the studies, things like sleep improvement, mood improvement. This suggests that using cannabis to help manage the side effects of cancer treatments or improve quality of life for cancer patients is a much more consistently supported area within the literature they analyzed.
So that offers clear guidance for healthcare providers in that specific context.
It seems so, yes. That area showed a stronger positive signal.
That aligns much more with how many people understand medical cannabis is currently used in oncology settings. Okay, what about the anti-inflammatory aspect you mentioned earlier? Was that also strongly supported?
Yes, this was another area where the analysis found robust support. The source states pretty clearly that data regarding cannabis and health metrics, particularly inflammation and biomarkers, indicate a strong and consistent consensus supporting the anti-inflammatory properties.
Strong and consistent consensus. That sounds much more definitive compared to the tumor growth finding.
It is. It suggests a clearer picture in the literature regarding anti-inflammatory effects. And this finding, the source notes, suggests broader applications beyond just oncology. It could potentially influence the treatment of other chronic inflammatory diseases.
Okay, so the anti-inflammatory potential of cannabis compounds seems pretty well supported in this large body of research they looked at.
That's the takeaway from the sentiment analysis on that topic.
Fascinating. Beyond cancer and inflammation specifically, did the analysis show a general consensus for therapeutic use overall, just using cannabis for medical reasons in general?
Yes, very much so. When they looked specifically at studies categorized under the broad topic of therapeutic use, using that keyword occurrence, KO method,
Counting the keywords again.
right, the numbers were really striking. Studies investigating therapeutic use were, get this, 638.08% more likely to present supported sentiments than not supported sentiments.
Wow, over 6 times more likely.
And 974.49% more likely to present supported than unclear sentiments.
Nearly 10 times more likely than unclear. Those are massive percentages. That really drives home the point about the overall leaning towards positive therapeutic findings in the published literature.
Exactly. It indicates a very strong signal in the research corpus that studies focused on therapeutic applications tend to report supportive findings. And using the other method, the dominant instance, DI method.
Classifying the whole paper's leaning.
Yes. The results reinforce this. They found an inverse relationship between not supported and unclear sentiments and the topic of therapeutic cannabis, meaning studies classified as predominantly not supported or unclear were less likely than the average study in the dataset to be about therapeutic cannabis.
So both ways of analyzing the sentiment agree. There's a clear and consistent consensus reported in the literature supporting the therapeutic use of medical cannabis generally.
That's the conclusion drawn from this extensive meta-analysis. They even specifically mention that the study of cancers, viewed as a subset of therapeutic use, also shows a consistent consensus in support of medical cannabis within the literature, with non-supported or unclear sentiments being even less likely for cancer studies than for therapeutic use studies overall.
Interesting. Were there any specific areas within oncology or related topics where the research was not clear or where findings were ambiguous according to this analysis? Any outliers?
Yes, the source flags remission as a notable outlier, specifically using the keyword occurrence methodology.
Remission, as in the cancer actually goes away or is significantly reduced.
Yes, that concept. The analysis found no significant supported sentiment reported for remission using the KO method.
No significant support.
Okay, furthermore, for the topic of remission, unclear sentiments were actually 45.13% more likely than not supported sentiments.
So when studies talked about remission, they were more likely to have unclear findings than findings actively saying cannabis didn't help with remission.
That's what the data suggests. It stands in stark contrast to the general picture for therapeutic use or inflammation.
It absolutely does.
The interpretation offered by the source for this finding is that remission is a topic that is either relatively untested or associated with highly variable or ambiguous results.
That makes a lot of sense, intuitively. Directly causing cancer remission is a huge clinical bar, much harder to achieve and definitively prove than, say, reducing nausea or improving sleep.
Exactly. So while the analysis points to strong support in the literature for palliative uses and anti-inflammatory properties, and a general positive consensus for therapeutic use overall, the direct impact on tumor dynamics, and especially remission, is still an area that appears complex, less clear, or possibly under-researched, according to this large-scale sentiment analysis of the existing literature.
And identifying these specific areas of clarity, like palliative care and confusion, like remission, is precisely how this kind of meta-analysis provides that roadmap for future studies, as the source states. It tells researchers where more focused and rigorous work is really needed.
It helps prioritize resources and efforts in a really complex field. Where do we already have a good sense, and where are the big question marks?
Right. Okay, let's shift gears a bit. Your sources really dig into the specific compounds within cannabis, especially THC and CBD. It almost feels like they're setting them up as competing characters sometimes, that villain versus hero framing that sometimes comes up. Let's explore what your sources say about the key differences between THC and CBD.
Yeah, the contrast between THC and CBD is definitely a major focus in several of the sources you provided. CBD, cannabidiol, is identified as the second most abundant cannabinoid in the plant after THC, tetrahydrocannabinol.
And the most well-known difference is probably that THC gets you high, and CBD generally doesn't, right?
That's the primary distinction most people recognize, and your sources confirm this. THC is psychoactive, while CBD is generally considered non-intoxicating. But their actions within the body, how they work pharmacologically, are also fundamentally different, and this explains a lot about their effects.
Okay, how do they act differently at that level?
Well, THC is what's called a partial agonist of the CB1 and CB2 receptors. These are major components of your body's own endocannabinoid system found throughout your brain and body, especially CB1 in the brain.
Agonist means it activates them.
Right, it binds to them and turns them on, partially in THC's case. This activation, particularly of CB1 receptors in the brain, is largely responsible for THC's characteristic psychoactive effects, the high.
Okay, so THC hits the main cannabinoid receptors. What about CBD?
CBD is different. It actually has a very low affinity for these same CB1 and CB2 receptors. It doesn't bind to them strongly or activate them directly in the same way THC does.
So it doesn't fit into that same lock very well.
Exactly. But what's fascinating, according to the sources, is that CBD acts differently as a negative allosteric modulator of both CB receptors.
Negative allosteric modulator. Okay, break that down.
Imagine the receptor as a lock, like you said. THC is a key that partially opens it. CBD doesn't really fit in the keyhole, but it binds to a different spot on the lock, that's the allosteric part. And by binding there, it subtly changes the lock's shape, that's the modulator part. The negative part means this change makes it harder for the main key, like THC or even your body's own cannabinoids, to open the lock effectively.
So it subtly interferes with the receptor, making THC less effective, which might explain why CBD is sometimes reported to reduce the intensity of the high from THC.
Exactly. That's the proposed mechanism for how CBD might attenuate or lessen THC's psychoactive effects. But CBD's activity isn't limited just to tweaking the CB receptors.
Right, you mentioned it hits other targets too.
Yes, your sources point out that CBD seems to target a wide array of other receptors and enzymes in the body. We're talking about receptors involved in serotonin signaling, which affects mood and anxiety.
Like 5-HT1A.
Exactly. Also, TRPV1 receptors involved in pain and inflammation pathways. PPARs involved in metabolic regulation, even receptors involved in dopamine pathways like D2 receptors and some opioid receptors. Plus, it inhibits an enzyme called FAAH.
FAAH, that's the one that breaks down anandamide, right? One of our body's own cannabinoids.
That's the one, AEA or anandamide. So by inhibiting FAAH, CBD might increase the levels of your body's natural endocannabinoids.
So CBD is like a multitasker, interacting with many different systems, not just the main cannabinoid receptors. It sounds much more complex than THC in a way.
But that's what the sources suggest. It has a much broader target profile, although it's fair to say the full implications and importance of all these different interactions aren't yet completely understood. There's still a lot to learn there.
Okay, so how do these different ways of acting THC directly hitting CB1, CBD doing this complex modulation and hitting other targets translate into the effects people experience, particularly around things like reward, addiction potential, and psychological states?
One of your sources provides a really clear contrast here, especially regarding reward and substance use disorders, or SUDs. Preclinical studies, mostly in animals, consistently show that THC has rewarding effects and is psychoactive.
It makes the animals want more.
Essentially, yes. Tests show they'll work to get it. And this is linked to THC's ability to affect the mesolimbic dopamine system, your brain's primary reward circuit. THC increases dopamine release in key areas like the nucleus accumbens, which is a common mechanism for drugs with abuse potential.
Okay, so THC taps into the reward system. And CBD, does it do the same?
This is a key difference highlighted in the source. Preclinical studies consistently show that CBD, unlike THC, does not produce rewarding effects or psychoactive properties on its own. Tests like conditioned place preference, where animals learn to associate a place with a drug reward, don't work with CBD. Electrical brain stimulation studies also support this.
And why not? Does it not affect dopamine the same way?
That seems to be the reason. The source suggests this lack of rewarding effect may be linked to CBD's inability to significantly alter extracellular dopamine levels in the ventral striatum, that key reward area, whereas THC does reliably increase dopamine there.
That makes sense. If CBD isn't directly jacking up the reward pathway like THC, it's much less likely to be addictive or produce a euphoric high.
Exactly. And the source goes even further, suggesting something quite intriguing, that CBD might actually be able to normalize or restore aberrant dopamine signaling and salience processing, how your brain flags things as important that can be disrupted by drugs like THC.
Wow, so it might not just be neutral, it might actually help fix the very system that THC or other drugs can throw off balance. That's fascinating.
Potentially, yes. And this leads directly to the idea of CBD as a potential therapeutic strategy for treating SUDs. There's growing preclinical evidence, again mostly from animal models, suggesting CBD can reduce craving, lessen withdrawal symptoms, and even reduce relapse for various drugs of abuse, including stimulants like cocaine and amphetamine, opioids like heroin, and also alcohol.
That's really promising in animal models.
Yeah.
What about in humans who are actually struggling with addiction? Is there clinical evidence yet?
The clinical evidence is described as less robust, but starting to emerge. One study mentioned found that CBD didn't seem to affect tobacco withdrawal symptoms, but it did significantly reduce craving for opioids for up to 7 days after administration in people with heroin use disorder.
Reducing opioid craving is huge.
It is. However, results with nabiximols, that's the product containing both CBD and THC, often known as Sativex, were reported as mixed when tested for treating cannabis dependence itself.
Interesting that the combination product wasn't clearly effective for dependence on cannabis itself in those studies. Maybe the THC component complicates things.
That's possible, or it could be dose, ratio, study design, lots of factors. The source also notes 2 individual case reports that describe CBD being effective in reducing craving and withdrawal symptoms for cannabis and other substances in 2 young people, a 19-year-old woman and a 16.9-year-old man.
Case reports are just single instances, but they can point the way.
Exactly. However, a significant gap explicitly noted in the source is the lack of preclinical studies looking at CBD for SUDs, specifically in adolescents.
Given the potential vulnerability of the developing adolescent brain and the rates of substance use in that age group, that seems like a really critical area for future research. We need to know if it works and is safe for younger people.
Absolutely. That was clearly flagged as missing information.
Okay, what about CBD's effects on neuropsychiatric issues? There's been a lot of discussion and some concern about the link between cannabis use, especially early use, and problems like psychosis.
Yes, this is another major area of focus and concern discussed in your sources. Chronic cannabis use, particularly with products that are high in THC and low in CBD, is associated with impaired cognitive function and an increased risk of neuropsychiatric problems.
The link between starting cannabis young and developing conditions like schizophrenia later in life has been quite controversial, hasn't it? Hard to prove cause and effect.
It has been, and the source acknowledges this controversy. It notes that confounding factors, things like underlying genetic predisposition, environmental factors, using multiple substances make it really difficult to establish a direct causal link. However,
Yes.
clinical evidence is increasingly suggesting that the likelihood and severity of these associated neuropsychiatric disorders seem to correlate with several factors. How often someone uses cannabis, the dose they use, the age they start using, and crucially, the THC content of the cannabis they use.
So the pattern seems to be that high THC, low CBD cannabis, used frequently from a young age, carries the highest association with these risks.
That's what the sources indicate, yes. And this leads directly into the discussion about the potential role of CBD in mitigating THC-related neuropsychiatric side effects. The hypothesis being explored is whether having adequate levels of CBD alongside THC might offer some kind of protection against these potential downsides.
Like the entourage effect idea, but specifically CBD buffering THC.
Kind of, yes, focusing on that specific interaction. But are the findings on CBD's protective effect against THC consistent? Does it reliably cancel out the bad stuff?
That's the key question.
And the answer seems to be not entirely, or at least it's complicated, which again highlights the complexity here. One study mentioned found that CBD's ability to counteract THC-induced anxiety seemed to depend on the specific ratio of THC to CBD use.
Okay, so the balance matters.
But then, a more recent double-blind study, which used different ratios than the first one, found no evidence that CBD protected against the acute adverse effects of THC on cognition or mental health outcomes.
Okay, so it's not a simple CBD automatically cancels out THC's bad effects equation. The specific ratio, the dose, perhaps even the specific negative effect being measured, anxiety versus cognitive impairment, might matter a lot.
Exactly. The interaction appears complex and isn't fully understood yet. Now, shifting slightly, what about CBD's potential antipsychotic properties on its own, independent of THC?
Right. Can CBD itself help with psychosis?
There are fewer clinical studies compared to preclinical ones, but the majority discussed in your sources do show beneficial effects in reducing psychotic symptoms, particularly in adults diagnosed with schizophrenia.
That sounds really promising for such a difficult-to-treat condition. Can you give us some details on those studies?
One key study mentioned in a couple of your sources treated schizophrenia patients with a fairly high dose, 1,000 milligrams per day of CBD for 6 weeks. They found that these patients showed fewer positive psychotic symptoms.
Positive symptoms meaning things like hallucinations or delusions.
Exactly, those kinds of symptoms. And they also showed improvements in cognitive function and overall daily functioning. Crucially, this was achieved without the significant adverse events often associated with conventional antipsychotic medications, like weight gain or movement disorders.
That lack of side effects is a huge potential advantage if it holds up in larger studies.
It absolutely is. However, context matters. Another study mentioned by Boggs used a lower dose, 600 milligrams per day for 6 weeks and found no effect on psychotic symptoms in patients who were already being treated with standard antipsychotic medications.
So maybe CBD works better on its own than as an add-on. Or maybe the dose wasn't high enough in the second study. Or it interacts with the existing meds.
All plausible explanations. It suggests the effect might depend on whether patients are treatment naive, the specific dose used, or potential interactions. But then there was another compelling trial that compared CBD directly to amisulpride, which is a common antipsychotic medication for treating acute schizophrenia.
Head-to-head comparison. What did that find?
Both treatments, CBD, at doses ranging from 200 to 800 milligrams a day, and amisulpride were found to be safe and effective in reducing symptoms. But the CBD group experienced significantly fewer side effects.
What kind of side effects were reduced with CBD?
They didn't experience the movement disorders, extrapyramidal symptom that can occur with amisulpride. They also had lower levels of the hormone prolactin, which some antipsychotics can elevate, and importantly, less weight gain.
Those are really important differences in terms of patient quality of life and long-term health risks associated with medication.
Absolutely. And interestingly, this study also found a positive correlation between the levels of the body's own endocannabinoid, AEA, or anandamide, and the clinical improvements seen in the CBD group.
Connecting back to CBD inhibiting FAAH.
Exactly. This suggests that one potential mechanism by which CBD might be exerting its antipsychotic effects is by inhibiting the breakdown of AEA, thereby boosting the levels and activity of the body's own natural cannabinoids. It points to a fascinating mechanism involving the endocannabinoid system itself, beyond just direct receptor interactions.
So CBD could be working, at least partly, by boosting our own natural brain chemistry related to cannabinoids.
That's a leading hypothesis raised by this specific piece of research. However, and this is important, the sources are very careful to note the limitations of these promising findings.
Right, the caveats.
Yes. Many of these studies are relatively small, they often have short follow-up periods, or they're based on single case reports, and the sources also include a critical counterpoint. They mention other case reports describing potential toxic side effects of CBD, and paradoxically, instances where CBD use was associated with increases in anxiety, depression, and even suicidal ideation in some individuals.
Wow, that's a stark reminder that even something generally considered safe and non-intoxicating isn't universally harmless or beneficial for absolutely everyone.
Exactly. And the potential for negative reactions might depend on an individual's prior experience with cannabinoids, their underlying health, or other factors. The sources explicitly attribute these sometimes opposing results, positive findings in some studies, no effect or even negative effects in others, to the huge variability in.
Let me guess. The CBD products themselves.
Yes. Pure CBD isolates versus full-spectrum extracts with unknown or varying cannabinoid ratios. Also, different doses, different ways of taking it, oral, inhaled, topical, and significant differences in the patient populations being studied. All this makes it really difficult to draw firm, universal conclusions about CBD's effects just yet.
This raises an important question then. What about CBD and anxiety specifically? We talked about it maybe interacting with THC-induced anxiety, but what about CBD's effect on anxiety on its own? That's one of its most popular uses.
Several sources definitely touch on this. Preclinical studies in adult rodents have pretty consistently shown that CBD administration reduced anxiety-related behaviors. It also seemed to decrease neuronal activity in brain regions known to be central to anxiety processing, like the amygdala and the cingulate cortex.
The brain's fear and emotion centers.
Right. And one source references a human study where acute CBD administration reduced cerebral blood flow in these emotional processing areas, these limbic and paralimbic areas, in patients diagnosed with social anxiety disorder. And importantly, this change in brain activity correlated with reduced physiological signs of anxiety, like skin conductance response.
So it seems to actually modulate, maybe calm down, the brain circuits that are typically overactive in anxiety conditions.
Yes, that's the indication from these brain imaging and behavioral studies. Other work in animal models of PTSD suggests that repeated CBD exposure might prevent some of the long-lasting anxiety-promoting effects of trauma, possibly through interactions with serotonin receptors, specifically the 5-HT1A subtype. So the general idea emerging is that CBD's anxiolytic effects, its ability to reduce anxiety, may be linked to this capacity to modify brain activity in these key emotional processing circuits.
Okay, that makes sense mechanistically, but here's where it gets really interesting. One of your sources looked not just at the effects of taking CBD, but at the effect of simply expecting to take CBD. What did that study reveal about the power of belief when it comes to anxiety?
Yes. That was a fascinating study design. It was a randomized crossover trial with healthy adults. In different sessions, participants were given CBD-free hemp seed oil. But crucially, they were told in one session that it contained CBD, that was the CBD expectancy condition, and in the other session, they were told it was CBD-free. Then they put them through an acute stress test.
So they were directly testing the placebo effect, linked specifically to the idea of taking CBD for stress.
Exactly. And the findings were quite insightful about how belief works. Expecting to receive CBD, even when they didn't, did have an impact on both subjective feelings and some physiological measures. Specifically, it increased participants' subjective ratings of sedation.
Okay, so just thinking they took CBD made people feel more sleepy or sedated.
That's what they reported, yes. It also led to some subtle changes in heart rate variability. That's a measure of the nervous system's stress response changes that the researchers interpreted as being consistent with heightened anticipatory stress regulation, like their body was bracing for the stressor differently because they thought they had CBD on board.
Interesting physiological effect just from belief. But what about the main outcome, feeling stressed or anxious?
This is where it gets nuanced. Overall, across all participants, there were no systematic changes in subjective stress or anxiety levels based purely on whether they expected CBD or not. The expectation alone didn't broadly reduce anxiety for everyone.
Wait, so the expectancy didn't reduce anxiety generally? I thought that was the whole point of the placebo effect.
Not universally, not just based on the expectation itself in this study. However, and this is the really key finding, the study found a powerful moderator. The participants' prior beliefs.
Well, they already thought about CBD.
Exactly. Participants who came into the study with strong prior beliefs that CBD is effective at reducing anxiety reported significantly diminished anxiety during the stress test, only in the condition where they expected to receive CBD compared to when they expected the CBD-free oil.
So for people who already believed CBD would help their anxiety, the placebo effect was strong enough to actually make them feel less anxious just by expecting it.
Yeah.
But it didn't work for people who weren't already convinced.
Precisely. This study really emphasizes the significant role that individual expectancies, your pre-existing beliefs, play in moderating the placebo effect. For participants who had low or only moderate prior beliefs about CBD's anxiety-reducing effects, there was very little difference in their anxiety levels based on whether they expected CBD or not. The effect of expectancy seems specific to those who are already strong believers in CBD for anxiety.
That's a crucial finding. It has huge implications for interpreting not just research results, but also anecdotes about how these products work in the real world. It means subjective feelings of benefit might be partly or even largely driven by what you already believe is going to happen.
It certainly highlights the importance of controlling for these expectancy effects in clinical trials, especially for subjective outcomes like anxiety or mood, and acknowledging their potential influence.
Absolutely. Okay, one last point in this section. Neuroinflammation. Your sources touched on this, particularly linking it to THC exposure during adolescence. What did they say?
One source discussed some limited preclinical studies on this, focusing on that adolescent window in mice. The findings suggested that THC exposure during adolescence seems to promote neuroinflammation that persists into adulthood.
Promote inflammation. How did that work?
Well, chronic adolescent THC treatment initially caused a reduction in some pro-inflammatory cytokines, markers of inflammation, shortly after treatment stopped. But later in adulthood, these same mice showed a pro-inflammatory immune cell phenotype in the brain, elevated levels of pro-inflammatory markers, and decreased anti-inflammatory ones. This suggests that the early THC exposure might trigger lasting immune system dysfunctions long after the exposure itself has ended.
So THC exposure during that critical period of brain development in adolescence could potentially have lasting negative effects on the brain's immune system, maybe predisposing individuals to immune-related or behavioral problems later in life.
That's what these preclinical findings in mice seem to suggest, yes. It looks like it triggers immune dysfunctions that could lead to increased vulnerability down the road. A significant gap noted in the source, however, is the lack of information on the effects of CBD alone, or a THC-CBD combination, on neuroinflammation specifically during adolescence.
Right, so we don't know if CBD might mitigate this or have its own effects during that vulnerable period. Another critical area needing research, especially given patterns of cannabis use among young people.
Definitely flagged as an unknown.
Okay, let's shift focus again to another major area covered extensively in your sources: how cannabis and its components affect our cognitive abilities and performance in daily life. Thinking, memory, reaction time. What picture emerges from this research?
This is obviously a key concern for many people, whether they're considering using cannabis medically or recreationally, or are current users, particularly regarding things like driving, working, or studying. Your sources tackle this directly. A consistent finding across several of them is that chronic heavy cannabis use is generally associated with impairments in cognitive function.
Okay, so long-term heavy use can have negative impacts on thinking and memory. That seems fairly established. But what about the acute effects? The effects you feel right after using, and how do THC and CBD compare here?
Neuroimaging studies, like those reviewed in one of your sources, give us some insight into how the brain responds acutely right after administration. They show that acute CBD administration can modulate brain activity and connectivity in neural systems relevant for psychosis and anxiety.
Which aligns with what we just discussed about its potential therapeutic effects.
Exactly. For instance, one study in healthy subjects found CBD increased functional connectivity between the right putamen, part of the basal ganglia, and the right prefrontal cortex.
And what happens in those emotion processing areas, like the amygdala, during stress or anxiety-provoking situations after taking CBD?
Well, as we touched on regarding anxiety, during tasks involving looking at fearful faces, acute CBD at a 600 milligram dose in one study was found to attenuate or reduce activity in key regions like the amygdala, the cingulate gyrus, and the cerebellum. And this dampening of brain activity correlated with reduced physiological signs of emotional response, like skin conductance. CBD also seemed to disrupt connectivity between parts of the anterior cingulate cortex and the amygdala during this task.
So acutely, CBD seems to calm down or alter the activity and communication in brain areas strongly associated with processing fear and emotional responses.
That's what these specific imaging studies suggest in the context they tested. Findings in individuals at clinical high risk for psychosis, or those already diagnosed, also indicated CBD showed intermediate activity somewhere between healthy controls and placebo in brain regions involved in reward and salience processing. This led to the suggestion that CBD might help normalize disbalanced frontostriatal activity in these conditions.
And the SPECT study.
The SPECT study, measuring blood flow, showed reduced cerebral blood flow in those limbic and paralimbic areas in social anxiety patients after CBD, further supporting this idea of CBD modulating activity in emotional circuits.
What about effects on brain chemistry, neurotransmitters?
There was also a spectroscopy study mentioned that added another layer. It suggested that CBD modulated levels of key neurotransmitters, glutamate and GABA, in different brain areas, increasing glutamate in one area, decreasing it in another, and having different effects on GABA in patients versus controls.
So potentially influencing the balance of excitatory and inhibitory signals.
Possibly. This adds to the preclinical evidence that CBD influences neurotransmitter systems beyond just the endocannabinoid system, though the precise functional role of these specific changes needs much more study. The authors of that review rightly emphasized the need for more studies, larger patient groups, and combining longer-term CBD treatment with imaging techniques to really solidify these findings.
Okay, that's the brain activity picture. Now let's look at studies that directly tested performance on actual cognitive tasks, especially those using standardized cannabis products like that Bedrocan review you mentioned. What did they find about acute effects on performance?
Right. Studies using these products with known defined THC and CBD content in healthy volunteers showed acute effects that were clearly dependent on the dose, particularly the THC dose.
Unsurprisingly.
Yes. Higher doses of THC were associated with slower reaction times and impaired accuracy on tasks designed to measure things like divided attention, sustained attention, learning, and working memory.
That confirms the general expectation. THC impairs cognitive function acutely, and more THC means more impairment. What about the CBD-dominant products used in those studies?
This is a really crucial finding highlighted in that review. CBD-dominant cannabis, specifically the product Bedrolite, does not seem to affect cognitive function.
Okay, so taking CBD alone, at least in these studies using standardized products and doses, didn't cause measurable cognitive impairment on the tasks they used. That's significant.
It is. Now, what about combining THC and CBD? Does adding CBD prevent or counteract THC's impairment?
The million-dollar question for many products out there.
And the answer from the studies reviewed was mixed results, indicating the interaction is complex. Interestingly, in one study, adding CBD at doses of 10-30 milligrams to a standard dose of THC, 10 milligram, did not actually change the levels of THC measured in the participants' blood.
Really? I thought CBD was supposed to affect THC metabolism.
It often does, especially via liver enzymes, but maybe not always or not significantly with these specific doses or routes. However, even though the THC levels weren't different in that study, the combination did affect the subjective experience. Participants reported feeling less high after the THC-CBD combination compared to taking the same dose of THC alone.
So CBD seemed to reduce the feeling of intoxication, even if it didn't change the amount of THC in their system in that particular study. Interesting dissociation.
It is, but then when they looked at performance on objective cognitive tasks, including simulated driving performance, verbal learning tests, working memory tests, attention tasks, the results were inconsistent across studies. Generally, THC-dominant products led to impairments. CBD-THC combinations sometimes showed less impairment than THC alone, but the sources also state that CBD didn't always fully counteract THC's negative effects on performance. And perhaps more surprisingly, one source explicitly notes the potential for CBD to actually exacerbate or worsen THC-induced impairment in some situations.
Exacerbate. Make the impairment worse. That's really counterintuitive. Why on earth might that happen?
Well, that big meta-analysis on acute CBD performance provides a possible pharmacological explanation. It mentions the potential for CBD to increase impairment when combined with other drugs, including THC.
Oh.
Because CBD can inhibit certain enzymes in your liver, particularly cytochrome P450 enzymes that are responsible for breaking down many substances, including THC, especially when they're taken orally. By inhibiting these enzymes, CBD could potentially lead to higher or longer-lasting levels of THC or other co-administered drugs in your system than you'd get otherwise.
So even if CBD itself isn't impairing, it could indirectly boost THC's impairing effects by slowing down its removal from the body.
That's the concern raised, based on pharmacokinetic principles. While, as we saw, some studies found no change in peak THC levels with CBD co-administration, others have suggested that THC levels do appear higher or last longer when CBD is present. It's a complex metabolic interaction.
That really underscores that the interplay between THC and CBD isn't a simple cancellation effect. It's a complex pharmacological dance involving metabolism and potentially leading to unexpected outcomes.
Precisely. It's not straightforward. Let's also look briefly at a specific clinical population. Individuals with cannabis use disorder, CUD. One of your sources described a clinical trial of CBD specifically for treating CUD, where cognitive function was assessed as a secondary outcome. They hypothesized that maybe CBD treatment would improve cognition in these individuals who often show some deficits.
Makes sense. What did that trial find about CBD's impact on cognition in people diagnosed with CUD?
It was a 4-week, randomized, double-blind, placebo-controlled trial, using either 400 milligrams or 800 milligrams of CBD daily. The main finding regarding cognition was that CBD treatment did not influence delayed verbal memory, which was their primary cognitive outcome measure. And overall, compared to the placebo group, CBD did not seem to have broad cognitive enhancing effects in this population.
So no overall cognitive boost from CBD for people with CUD in this particular well-controlled study.
That's what they found, broadly speaking. There was one potential exception noted. The higher dose, 800 milligrams daily CBD, may have improved performance specifically on a task measuring working memory manipulation, the backwards digit span task. Participants in that group showed an increase compared to the placebo group, but this was a secondary finding.
How does this result compare to earlier studies that had suggested CBD might improve cognition?
The source itself contrasts this finding with an earlier open-label trial, meaning no placebo control, which did find better verbal learning and memory with a lower dose of CBD, 200 milligrams. However, the authors of the CUD trial rightly suggest that the improvement in the earlier study might have simply been a practice effect as participants repeated the tests.
Getting better just by doing the test multiple times.
Exactly. Another very small single-dose study also found some improvement in verbal memory. The more recent CUD trial had a larger sample size and, crucially, that placebo control group, which really highlights the importance of rigorous methodology in getting reliable results, even if those results sometimes challenge earlier, less controlled findings.
Absolutely. Okay, you mentioned earlier there was a meta-analysis specifically looking at acute CBD performance effects across multiple studies. That seems like potentially the most definitive source on what happens right after taking CBD alone. What did that large review conclude?
Yes, that meta-analysis synthesized data from 16 controlled human laboratory studies. These studies specifically looked at the effects of acute CBD administration, meaning effects measured within 0 to 8 hours after taking it on various performance measures compared to a placebo.
And the bottom line, does acute CBD impair performance, yes or no?
Well, the overall analysis, when they combined all the studies and all the different types of measures, did find a statistically significant effect. And this is crucial, the effect size was very small. The Hedges G-value was only 0.122, indicating a small degree of impaired performance following acute CBD compared to placebo.
Okay, so there was a statistically detectable level of impairment across all studies combined, but the actual magnitude of that impairment was small.
Yes, a tiny overall effect size. And this is where the moderator analysis becomes absolutely key to understanding what's going on. When they broke down the results by the type of measure used in the studies,
Subjective versus objective.
exactly, they found that the larger mean differences, the results indicating more impairment, were seen almost entirely when using subjective measures. Specifically, participants' self-reported feelings of sedation. The effect size for sedation was much larger, G 0.288.
So people felt more sedated after taking CBD, and that subjective feeling contributed the most to that overall small impairment finding.
Precisely. When they looked only at the results from objective performance tasks, tests measuring actual cognitive abilities like memory, attention, reaction time, or physical coordination like balance or simulated driving.
What did they find for those objective tests?
They found no difference from placebo. The effect size for objective tasks was negligible, G is 0.048, and not statistically significant.
Wow. That's a really, really important distinction for anyone wondering if they can function after taking CBD. It might make you feel a bit sleepy or out of it, but according to this large analysis, it didn't measurably impact objective performance on cognitive or motor tasks in these controlled lab settings.
Exactly. That's the core finding. The meta-analysis also directly compared the magnitude of acute CBD effects to acute THC effects reported in similar studies. Unsurprisingly, THC caused a significantly greater magnitude of impairment compared to CBD overall. G equals 0.416 for THC versus G 0.122 for CBD.
Okay, that aligns with the general experience in the other research we've discussed. THC is clearly more impairing.
So the clear conclusion drawn from this comprehensive meta-analysis is that acute CBD consumption taken alone was associated with a small increase in subjective ratings of sedation, but importantly, no difference from placebo across multiple domains of objectively assessed cognitive or psychomotor performance.
So the practical takeaway for acute CBD alone is that it's unlikely to significantly mess with your ability to do daily tasks or perform safely at work.
That's the implication drawn by the source. They state it's unlikely to significantly impair daily functioning or workplace performance. That's a pretty clear signal from a large body of controlled evidence.
It really is.
However, they do add that important caveat we discussed earlier.
Right, the interaction potential.
Yes. Remember the potential for CBD to increase impairment when combined with other drugs, including THC, potentially due to inhibiting metabolism, especially after oral ingestion. So, while acute CBD alone appears relatively benign for objective performance, using it in combination with THC or other potentially impairing substances warrants caution and definitely needs more research to fully understand the risks.
Okay, that's a crucial distinction. What about the overall safety profile then? Beyond performance effects, what do the sources say about general safety, especially for those standardized products you mentioned? And what kind of side effects did the studies actually report seeing?
The review focusing specifically on the standardized Bedrocan products provides good insights into this as it looked at studies using defined composition cannabis.
And what was the main finding regarding safety in those studies? Were there serious problems?
The review states, quite emphatically, none of the studies reported serious adverse events as response to medicinal cannabis. So no major safety issues emerged in that specific set of studies. All the side effects that were experienced were described by the participants or researchers as mild.
That's certainly reassuring for those specific standardized products used under research conditions. What were the most commonly reported mild side effects then?
The most frequent ones mentioned included lightheadedness, particularly right after inhalation that was reported by 88% of participants in one study. Also, the feeling of a drug high, which varied quite a bit, reported in 20% to 80% across different studies, likely depending heavily on the THC content of the product used.
Makes sense. What else?
Coughing was common, again likely related to inhalation, reported by 10% to 70%. Mental confusion was reported by a significant minority, 25% to 37% in some studies. And sore throat and experiencing a bad taste during inhalation were also mentioned, affecting 25% to 35% in some studies.
It sounds like quite a few of those are directly related to the method of delivery, specifically inhaling smoke or vapor.
Yes. The source explicitly notes that side effects like coughing, the immediate lightheadedness, and sore throat were particularly related to cannabis inhalation and typically resolved pretty quickly, within minutes.
Were these studies designed well enough to distinguish side effects caused by the cannabis itself versus symptoms that might have been part of the underlying medical condition being studied?
That's a limitation the source highlights quite clearly. Only 2 of the reviewed studies using these standardized products were actually placebo-controlled. This makes it, as they say, challenging to distinguish between side effects related to cannabis treatment from those associated with the medical condition itself.
Right. If someone has chronic pain and feels fatigued, is it the cannabis or the condition? Hard to tell without a placebo group.
Exactly. It muddies the water a bit in interpreting those side effect reports.
Fair point. What about dropout rates in these studies? Did the side effects, even if mild, lead people to stop using the products?
There was actually a large difference in dropout rates across the various studies reviewed, which seemed to be related to how frequent and how severe the side effects were experienced by the participants in each specific study. Some studies reported 0% dropout specifically attributed to side effects.
Okay, so some people tolerated it very well.
Yes. However, other studies had quite high dropout rates. For example, one study reported a 49% dropout rate after just 3 months of treatment, with mental confusion being cited as the primary reason for participants stopping the treatment.
Wow, nearly half the participants dropping out due to mental confusion is a pretty significant impact, even if classified as mild overall.
It really is. That suggests that side effect, while maybe not medically serious, was functionally problematic for many users in that study. The review also made an interesting observation. Studies involving patients who had more prior experience using medical cannabis tended to report lower dropout rates due to side effects.
Ah, so maybe experienced users know what to expect or how to manage their dose better, or perhaps they've developed some tolerance to those initial side effects like confusion or lightheadedness.
That's the speculation, yes. It suggests experience might play a role in tolerability.
What about adverse events reported in the clinical trials of CBD you mentioned earlier, like the schizophrenia or CUD trials?
Well, the CBD trial for schizophrenia by Boggs, which we discussed, reported that CBD was generally tolerated well with similar adverse event rates reported between the groups, CBD versus placebo. Interestingly, looking at a table referenced in one of your other sources, it seems sedation was actually reported more frequently in the placebo group than the CBD group in that particular study.
Huh. That's quite surprising, especially given the subjective sedation reported as a key finding in the acute performance meta-analysis. Shows how context matters.
It really does. Effects can vary significantly by population, dose, duration, and study design. The CBD trial focused on cannabis use disorder mostly discussed cognitive outcomes in the excerpts you provided, so we don't have detailed adverse event reporting from that specific material to draw on. And the acute CBD performance meta-analysis, by its nature, focused on immediate performance outcomes and subjective states like sedation, rather than tracking clinical adverse events in a medical treatment sense over time.
Okay. So, pulling that safety information together, the picture from these specific sources regarding standardized products seems to be serious adverse events were not reported in these studies, but mild side effects are common, particularly things related to inhalation or associated with higher THC content, like feeling high or mental confusion. And that mental confusion, while maybe mild medically, can be significant enough to cause a substantial number of people, especially inexperienced users, to stop using the product. But the lack of many placebo controls makes it hard to definitively attribute all reported symptoms solely to the cannabis.
That summarizes the safety information presented in your sources quite well. Mild, but sometimes functionally impactful, side effects are common, serious ones rare in these contexts, but interpretation requires caution due to methodological limits.
Right. Now, beyond the general findings and the compound-specific effects, did the sources happen to mention any specific medical conditions where cannabis or CBD showed particular promise, or where they were being used effectively, perhaps highlighted in case studies or approved uses?
Yes, definitely. The review of standardized Bedrocan products included information from patient studies and also some specific case studies focusing on particular conditions. The patient studies generally examined the impact on pain-related and other medical conditions.
Okay.
And the overall suggestion was that treatment with these standardized products seemed to reduce pain intensity across a broad range of chronic pain-related medical conditions.
So chronic pain management seems to be a consistent therapeutic area popping up in these studies using standardized cannabis.
It does appear frequently. Then there were a couple of specific case studies mentioned that provided more dramatic, though anecdotal, examples. One was regarding Tourette's syndrome.
Tourette's? Interesting.
Yes. Inhalation of a Bedrocan product reportedly led to a 70% reduction in tics in one case study patient, and perhaps even more strikingly, complete remission of tics in another case study patient.
Complete remission.
Wow. The source noted that the patient with the 70% reduction initially experienced a high feeling, which later disappeared with continued use, while the patient who experienced complete remission reported no side effects at all.
Those are certainly remarkable individual outcomes. Of course, we have to remember case studies aren't the same as rigorous clinical trial evidence for the whole population.
Absolutely. They're hypothesis generating, not definitive proof. But they do highlight potential areas of significant benefit that might be worth investigating more formally. Another case study mentioned involved hypermobile Ehlers-Danlos syndrome.
That's a connective tissue disorder, right?
Right.
Causes joint hypermobility, pain.
Exactly. In that case study, using Bedrocan and another product called Bedicay via inhalation was reported to lead to significant improvements in the patient's quality of life, better pain management, a reduction in the frequency of joint dislocations, and remarkably, even enabled the patient to regain the ability to walk independently.
That's a huge improvement in daily function and mobility reported in that specific case.
It is. The review also provided some context by listing specific cannabis-based products that have actually been approved for medical use in the Netherlands, where Bedrocan is based. This gives some insight into conditions where the evidence base from various sources has been deemed strong enough for formal recognition, at least in that jurisdiction.
The products and conditions were mentioned.
They mentioned Sativex, which is that CBD THC oral spray, approved there for treating spasticity related to multiple sclerosis, MS, and also Epidiolex, which is the CBD-only oral solution, approved for treating seizures associated with rare, severe childhood epilepsy syndromes like Lennox-Gastaut syndrome and Dravet syndrome.
Right. Epidiolex is a product we've heard about being approved in the U.S. and other places too, specifically for those difficult-to-treat epilepsies.
Yes, and another one of your sources also explicitly mentions Epidiolex in the context of treating refractory epilepsy, including related conditions like tuberous sclerosis complex and infantile spasms, epileptic spasms, reinforcing its established therapeutic potential in managing severe seizure disorders, particularly in children.
So that seems like one area with quite solid evidence leading to approval.
It does. That same source also provided a much broader list of potential therapeutic effects being investigated or suggested for CBD elsewhere in the scientific literature, covering a really wide range of conditions. Things like diabetes, various gastrointestinal issues, cancer, beyond just palliative care. Oxidative stress, inflammation, as we discussed, cardiovascular disease, and a variety of neurological or psychological disorders, including movement disorders like dystonia, schizophrenia, epilepsy, beyond the severe syndromes, Parkinson's disease.
Wow, that's a huge list of potential applications.
It is. It reflects the breadth of preclinical research and early clinical interest.
So pulling that together, it sounds like while chronic pain management and certain severe epilepsies appear in your sources, with specific examples, standardized product use, and even approved medications, the broader literature suggests potential therapeutic applications for CBD, and perhaps cannabis more broadly, across a much wider spectrum of conditions. Although presumably the strength of the actual evidence would vary significantly across that spectrum.
That's exactly the picture painted by the sources you provided, a mix of some more established uses where evidence has accumulated, alongside a vast landscape of potential applications that are still under active investigation, with varying levels of supporting data so far.
Okay, let's try to connect all these dots. We've gone through a lot of detail from the sources you provided. What are the main takeaways when we synthesize everything?
Well, first, it's crystal clear that the research landscape for cannabis is inherently complex and heterogeneous, just really diverse. But these advanced methods, like the sentiment analysis we discussed, can actually help provide an overall picture, a sort of temperature reading across thousands of studies.
Right, and that overall picture from the sentiment analysis showed a general leaning towards positive or supportive findings being reported in the literature, particularly for therapeutic use in general, but with really important nuances in specific areas like cancer remission, where the consensus seems much less clear or possibly untested.
Exactly. And within that, specific areas where your sources indicated a strong and consistent consensus emerging from the literature include the anti-inflammatory properties of cannabis compounds and its usefulness for palliative care in oncology managing symptoms like pain or nausea. Those seemed quite robustly supported in the sentiment analysis.
It's also abundantly clear from your sources that THC and CBD are fundamentally different compounds. They have really divergent effects, especially when you look at the brain's reward pathways and their psychoactive properties. CBD doesn't seem to be rewarding or addictive on its own, based on preclinical work.
Right.
And there's that intriguing suggestion, though still being explored, that CBD might counteract or mitigate some of THC's negative neuropsychiatric effects. But crucially, the interaction between them is complex, it's not simple cancellation, and it likely depends heavily on factors like the dose and the ratio of the two compounds.
That complexity definitely extends to the cognitive effects, too. While chronic use of high THC cannabis is consistently linked to impairment, that big meta-analysis on acute CBD performance was pretty striking. It showed CBD alone didn't objectively impair cognitive or psychomotor performance compared to placebo in lab settings.
Even though it did make people feel more sedated subjectively.
Right. THC, on the other hand, causes significantly greater objective impairment. However, and this is a critical caveat running through the sources, combining CBD and THC can be unpredictable. It might lessen some effects, but could potentially increase overall impairment, partly due to those complex metabolic interactions where CBD might slow down THC breakdown. That needs real caution.
Yeah, that interaction piece is key. The review of standardized products reinforced that higher THC doses tend to lead to cognitive impairment, while the CBD-dominant products didn't seem to.
And regarding safety for those products,
The picture was generally mild side effects, often related to inhalation or the THC dose itself, like feeling high or experiencing mental confusion. Serious adverse events seemed rare in those specific studies, but that mental confusion could be significant enough to cause high dropout rates in some studies, particularly among less experienced users. And the lack of placebo controls often makes definitive attribution tricky. And the research on CBD's effect on cognition in specific populations, like folks with cannabis use disorder, seems still quite early and evolving. One trial you mentioned showed some potential minor benefit in working memory at a high dose, but didn't find broad cognitive improvement compared to placebo overall.
correct. And the neuroimaging studies provided those fascinating glimpses into how CBD might be working in the brain, potentially modulating activity in areas related to anxiety and psychosis, which aligns nicely with its potential therapeutic uses in those areas. But again, many of those clinical trials are still small and need replication with larger groups and longer follow-up.
And maybe one of the most thought-provoking findings from a research perspective was that study on expectancy. It really hammered home how subjective experiences, like feeling less anxious after supposedly taking CBD, can be powerfully influenced by a person's prior beliefs. The placebo effect is real and potent, especially for these kinds of outcomes.
Absolutely. It highlights the inherent complexity of studying substances that affect consciousness or relieve symptoms, and the critical importance of careful, controlled study design, while also acknowledging the undeniable role of individual psychology and belief in shaping perceived outcomes.
So what does all this mean? For you, our listener, who brought us this fascinating collection of material, these sources really offer a rich, if sometimes complicated and contradictory, picture of where the science stands. Understanding the inherent challenges of this research field, the heterogeneity, the mix of study types, the sometimes conflicting findings is absolutely crucial for you to critically evaluate the information you encounter about cannabis, whether it's in headlines or product marketing.
Definitely. And the identified areas where there seems to be a stronger consensus emerging from the literature, particularly around anti-inflammatory effects and palliative care uses, represent important steps forward. They can help inform both clinical practice where appropriate and, perhaps more importantly right now, help direct future research efforts towards refining those uses and understanding them better.
Understanding the distinct effects of THC versus CBD is also vital. Given the huge variety of cannabis products available, many with poorly defined or inconsistent contents, knowing that these two major compounds act very differently is critical. Not all cannabis is the same, and the effects you might experience will depend heavily on the specific cannabinoids present, their amounts, and their ratios.
And that finding about acute CBD alone being unlikely to significantly impair objective daily functioning is a practical takeaway for many people. It might alleviate some concerns about using CBD products during the day. However, that needs to be balanced with the awareness of potential complex interactions when CBD is combined with THC or other drugs. Caution is always necessary, especially when combining substances due to those metabolic interactions we discussed.
Right. And the gaps noted throughout these sources, the lack of clear evidence for effects on cancer remission in that big analysis, the need for much more research on the long-term effects of both CBD and THC, particularly regarding things like neuroinflammation in adolescents, the variability we see in clinical trial outcomes for things like psychosis or CUD treatment. These clearly highlight the key areas where more rigorous, well-designed studies are desperately needed to build a truly comprehensive and reliable evidence base.
We're still filling in major pieces of the puzzle.
And finally, that profound influence of placebo and expectancy effects, especially on subjective outcomes like anxiety reduction. It really underscores the need for researchers to use careful methodologies like blinding and placebo controls, but also for all of us to consider the role of individual psychology and belief when we interpret both scientific findings and personal experiences with these substances.
And the variability in responses seen across the board, from differing dropout rates in the standardized product studies based on experience to how individual beliefs shaped subjective anxiety responses, also emphasizes that even as the science advances, the effects of cannabis products can be highly individualized. What works for one person or causes side effects in one person might be very different for another.
So you've given us this incredible collection of material, and what really emerges is a picture of a scientific field that's incredibly active, it's making real progress, it's uncovering clear benefits and mechanisms in some specific areas. But it's also grappling honestly with immense complexity, sometimes frustrating contradictions, and it's essentially laying out a clear roadmap for where future research needs to focus its energy and resources.
Right.
Thank you so much for bringing us this stack of sources and allowing us to take this deep dive with you. It's been a truly fascinating exploration of the cutting edge of cannabis research, all seen through the lens of the material you provided.
It really has. It perfectly illustrates the dynamic nature of scientific discovery in a rapidly evolving field full of both exciting potential and some significant ongoing challenges.
And here's something for you to mull over as you continue your own learning journey on this topic. As we continue to gain more and more detailed, sometimes contradictory data from all these different types of studies, from sentiment analyses of thousands of papers down to individual case reports or controlled trials, how do we best translate this incredibly complex, constantly evolving scientific understanding into clear, reliable, and practical guidance that healthcare providers and individuals like yourself can actually use effectively and safely in the real world?
Yeah, that journey from aggregate research findings like sentiment trends or average effects in a trial to truly personalized, evidence-based standards of care is clearly still underway. Bridging that gap between population-level data and individual patient needs and responses remains a central challenge in this field and maybe in medicine more broadly.
Definitely something to think about. We hope this deep dive has provided you with some valuable clarity and insights drawn directly from your sources. Join us next time on The Deep Dive.